So hi, welcome to part two of our session looking at becoming a First 5 GP. And today I'm going to talk a bit about resilience. Now, resilience has had a bit of an interesting past over the couple of years that have gone by, in that it came through as this sort of new concept that we were all to adopt to make us more resilient to the challenges that general practice was going to face us. Lots of resilient resources were discussed, and then if you're a member of the RCGP, you got sent a colouring book and a little journal to think about your life. As you can imagine, that went down a bit like a lead balloon, and a lot of people started to speak out about resilience, saying that actually trying to focus on clinicians and their resilience was perhaps the wrong approach. I think, as with most things in life, there's a bit of both that's true here. So I want to talk a little bit around what I think you should see as resilience. Can you guess who my quote's from? Yes, it's Epictetus again. Again, my chilled out philosopher friend from ancient Greece. So man is affected not by events, but by the view he takes of them. What does that mean? Well, I think it's essentially saying that the same event can affect people in different ways, and a lot of how we perceive what's going on in the world is our perception of events rather than necessarily an objective view of things. That's the nature of being a human. Everything we experience is subjective. Now, that might sound incredibly obvious, and you might think, well, why is he telling me this? I'm not an idiot. Of course, how I perceive the world is how it is. It's not how other people might see it. But I think it's something we do forget quite easily, that our experience is not necessarily what everyone else's experience is. And I'm sure most of you have had a kind of patient encounter at some point where you feel things have gone really well, but the patient doesn't, and you might get a complaint, say, out of complete surprise. To use another example, I often talk about chronic pain with patients and reference the idea that if you've got kids who are running around, they fall over while they're playing, they're having a really good time, they scrape their knee, but they just get up and carry on playing because they're enjoying themselves. But if we switch the situation to they're running away from you because you've tried to tell them off for being naughty, they run along and fall and scrape their knee, then all of a sudden it's lots of tears and upset, even though objectively the actual grazed knee is the same injury. So really, I guess what I'm trying to say is that part of developing your own resilience has to be about looking at how you view the world around you and recognizing how you do that. I bang on all the time about the idea of knowing yourself, and I really can't stress it enough here. If you understand how you're going to react to kinds of situations, then you can often anticipate what's going to happen, and that might lead you to develop some mechanisms that avoid you from becoming upset or angry by events that are not within your control. So I think a good example of that is the HALT, H-A-L-T acronym. I may have discussed it with you before, you may have heard it in other places. But the idea is that if you're starting to feel a bit cranky at work, you need to halt or stop and think about H, am I hungry? So go get yourself a little snack. Maybe you need a cup of tea made, that kind of thing. Are you A, angry about something or anxious about something? If so, go and deal with what that issue is, because you're just going to carry it through to the next patient that you have to see. Are you late? So running late can be really tiresome on someone. So maybe you need to build extra time into your clinics in order to see people, or develop strategies so that consults don't run over the time frame. And T is for tired or toilet. If you need a wee, go for a wee. There's no point holding it in because your focus will be divided. I appreciate we're all adults here, but as doctors, we often laugh about and almost boast about the amount of time we can go without emptying our bladder. Yes, it's amazing, but actually, general practice is a marathon, not a sprint. And it's dead important that you look after yourself in that long term. And thinking of that long game, if you're tired, so because you went to bed late last night because you watched just one more on Netflix before it kicked you off with that sort of embarrassing, are you sure you're still watching this program? Do you really want to watch another? I'm going to make you click because I think you've fallen asleep. But yeah, if you're tired, that has an impact. So planning ahead and thinking, well, how much sleep do I need to feel okay? Going to bed at an appropriate time. Again, none of these things are really that new concepts, I hope. I guess the point of me talking about them is so that you really think about them as integral to your work day, as opposed to just sort of nice ideals that we think about from time to time, breeze away. They're dead important to everything that you do. So, what is resilience, especially with regard to being a GP? So I quite like this definition, and you'll find lots out there. They all run to a similar theme. So Neenan has described it as a set of flexible cognitive, behavioural and emotional responses to acute or chronic adversities which can be unusual or commonplace. These responses can be learnt, and what categorises them so much is that they define you coming back from adversity. So it's not sort of a bounce back. It's not as simple as just dropping the ball and you bounce back up without any effort. There is effort required there. So this is dropping a bag on the floor and having to pick it back up. So another way to put that would be, I would describe it as advancing despite adversity. So to split that into the three components, advancing, what I mean by that is thinking, well, what is my goal? And let's make sure I'm working towards that vision. Now, I've gone through some psychotherapy, including something called ACT, which is acceptance and commitment therapy. And the idea of this is that for natural born warriors like me who get anxious about things, we can tend to overthink and get distracted from what the goal is we're actually trying to achieve. Now, some of you may remember back in ST1 or at the beginning of ST3 when you've had to draw your bit of paper with what you want your life to look like. You may have done golden tickets as part of the Windmills program if you did that in foundation training. You may have done previous work yourself just thinking, well, what is it I want to achieve? Where do I want to be in 10 years? Those kind of daydreams that we have when we're on holiday, thinking where we want our life to take us. Knowing what your goal is really, really important, because you can get through a lot of things if it's worth it in the end. So, for example, I imagine a lot of us have done locum shifts before, often in A&E on a sort of less than desirable shift, because the money we've earned from that has let us go on a nice holiday. Now, take away the holiday from it, and you kind of think, well, what's the point? Maybe you do the locum work because you enjoy it in its own right. And again, that's some way that you've derived some pleasure in your life, and that's made you feel happier. To put it in a more sort of GP focused context, if you want your life to kind of be, well, I want to have kids and a family, I want to be able to take them to school some days, well, your goal probably is to do something like some kind of part-time work, whether that's sort of middle of the day working or only working so many days per week in order to achieve that. So if that's the case, you've got to start thinking, well, if I'm going to work like that, do I become a locum? Do I look for a practice where, I don't know, there are lots of other people who've done that, so they'll be used to it, or conversely, a practice where everyone else is happy to work all the time, so it doesn't matter if I'm off. And there's some examples of trying to work towards your vision. So thinking, well, I want to achieve this goal of being a part-time GP, so I need to find somewhere where I'm going to fit in and be able to do that. When I do some careers teaching with the foundation doctors, we talk about the example of someone who wants to be, say, a cardiothoracic or paediatric surgeon, but also wants to live in a country house out in rural Lancashire. Their goals just aren't compatible with each other because realistically, they're going to have to work at a massive teaching hospital. And for the 8 years or so of their training, they're going to have to be prepared to travel around the UK to get that training. So they have to decide, well, if I really want to live in that house now, then maybe I can't do that training program because it's just not going to fit what I want. Conversely, it may be that they say, well, in 8 years' time, when I've done all my work, I'll then be able to settle somewhere in a nice country house, work, I don't know, at Preston, and then be able to make that work out for me. And in that example, I guess what I'm trying to say is that we can all have daydream visions that are completely unrealistic. So it is important that your goals are realistic and achievable, even if they seem far-fetched at the moment or a long way away. I've sort of slipped into the next section here, really, which is about being proactive. So don't wait for the challenges to come along. Sometimes things are really anticipatable. So an example I would give is perhaps of when I was a junior doctor, I looked ahead at the medical rota for the ward cover and realised that as an F1, I was the only junior doctor below the grade of ST3 available for 5 medical wards on one day. So having noticed that sort of a month in advance, I was able to take that to the rota coordinator who realised they'd made a mistake, and it wasn't then a problem. Now, I could have left it for the day and tried to manage, but I know that I'd have been really upset working that day. I've got colleagues who would be like, well, you know what, it's not my problem to deal with. And if on the day I'll just do what I can and it won't bother me. And I think that's an example of really thinking, well, if I understand myself and what upsets me or what motivates me, then tailor the situations to suit me. Unfortunately, whatever your goal, however lucky you are in life, there is going to be adversity and challenge that comes along the way whenever you least expect it, and sometimes when you really don't need it. If you're sort of a visual person, you might like to think about sort of a long winding road up to a mountain. At the top of that mountain is where your goal is that you're heading towards. And along the way, there are things like, I don't know, a ravine that you've got to cross, which has got really strong winds that might blow you off the side of the mountain, or I don't know, a horde of angry hyenas or whatever lives on a mountain. If I sort of plan ahead for my trip, well, I might take some good wet weather gear so the wind doesn't really get me so much, or figure out when the wind's going to blow so I can avoid traveling at those times, for example. And the other thing that's really key about that is that then I don't get distracted by those problems along the way. So, you know, I could get to the hyenas. I think they need to be mountain lions. I'm going to have to change my analogy, but there we go. So I get to them, and one strategy for dealing with them is, well, actually, I spend years and years with them, charming them, they'll become my friends, and then they won't want to eat me. Well, that's all well and good, but in that time, I've not progressed anywhere towards my goal. So I've spent all my energy focusing on dealing with some adversity. It's had absolutely no impact or benefit to me in getting where I want to be. So sometimes, you know, we're easily distracted by the challenges and adversity, and it stops us seeing the bigger picture. And actually, by refocusing on that, can encourage us to get where we need to go. So maybe I just need to kill each of those hyenas / mountain lions to get where I need to go. And lastly, I think it's really important to recognise that adversity doesn't have to be massive things like hordes of roving mountain lions / hyenas. Adversity can be something as simple as another doctor just doesn't ever hold the door open when you're following them up the corridor, and you always have to go and then reopen it. Over years, you build up a seething resentment to this doctor because they just don't do this one thing, and it's completely irrational, which you know, but instead of dealing with it, you just hold it inside you, and it becomes this real resentment to the point where one day you end up just snapping at them for doing something not really that bad, but because actually you wanted to vent the problem that has been bothering you. Equally, to reflect back to the idea of halt, the fact that you might just need a wee might be all you need to reset yourself on the course. And sometimes we can really be hard on ourselves, thinking that, well, if it's not that big a challenge, I should just deal with it and put up with it. That's not always the case. Sometimes being proactive in dealing with those smaller challenges that niggle away at us is just as important. And an analogy I'd think about with that is, if someone drops a house on my head, that's going to be really problematic, isn't it? But actually, so equally is someone throwing the same number of bricks used to build that house one at a time at me. It's the same kind of thing, just receiving it in different ways. So really, in summary, the idea of resilience is that you identify potential problems, stay focused on your goal, and work towards that, trying to meander your way through those difficulties as they present. Now, this is a fairly old tweet, a few years old now, from Claire Gerada, who's a former president of the Royal College of GPs. I think it's a really important quote to bear in mind, because a lot of the criticism of resilience and resilient teaching is essentially what she's saying, which is that the failings of a system are put on individuals to try and fix. And I think that's a really key and important thing to never forget, is that sometimes there is only so resilient you can be to a system that's trying to beat you down. So resilience should never be something that someone else is forcing on you in order to accept a condition that you don't think is workable. I remember once having this recurring nightmare that this is bizarre. I'm just going to go off on one. There we go. It's Monday evening. So my nightmare is that I woke up. I was woken up by sort of MI5 or whatever kind of agents in my house in Manchester, and I was told to get into the back of this black car. And I was driven back to my old school in Southampton, which had been turned into some kind of field hospital for a disease I wasn't even aware had occurred. I think this was around the time of Ebola, so maybe that was a disease, but I don't really remember the details. And in this example, Theresa May was at my school because she was the Prime Minister at the time, and I was told I had to run the hospital by myself. So I was the only doctor that was available to do this, and I alone was going to have to manage that. And this obviously sent me into floods of panic because I was like, well, I can't do this by myself. It's just impossible. And I was told, well, if you don't do it, it will all be blamed on you. We've told everyone it's up to you to deal with that. And that probably comes from a time when I was a fairly new GP, feeling like I was having to take on all these new things and I didn't really know what I was doing and that I couldn't cope with it. And I suspect looking back that dream was kind of around that. But it's a real reminder for me that there are some scenarios whereby it doesn't matter how freaking resilient I am, I would not be able to handle that situation. So I guess the importance of resilience is knowing what bit is you and what bit is someone else. If we've managed to upskill you so that you can recognize how you work and understand your own ability to get through challenges and adversity, and you're still struggling, well, maybe it's not you that needs to change. And by knowing that, you can more confidently take on and challenge a system where that's the thing at fault. The relevance of that will come on another day when we go through some scenarios talking about transfers of work from secondary care to primary care. I think knowing what you are supposed to do as a GP in the face of a consultant who you used to work for on a ward, perhaps telling you what they think you should be doing, it's important that you have that confidence to know your place in the world. So this slide contains some information about a little study, and it is only little. It's 17 family physicians in Canada, which has a broadly similar-ish primary care system to us. It's slightly different in terms of access and what the physicians are considered able to do, but vaguely comparable in terms of workload and the kinds of things they're dealing with. And I think the importance of this is really to just show that resilience is something that we all practice and probably do anyway. And like a lot of things that we do in general practice, it's about actually defining it so that if we're struggling, we've got a framework to go back to recognize what we need to do to kind of get back on the horse, as it were. So these 17 doctors were interviewed about what they thought constituted their idea of physician resilience, and they came up with 4 sort of broad themes. So this was divided into attitudes and perspectives. So this was looking at yourself as a doctor, making sure you remained interested in what you did, continuing to learn with that, and recognizing your own limits. It was about valuing your job as a doctor and other people valuing it also. The next idea was around balance and prioritization. So this was the idea of, taking that, you're a valued physician, you take that idea. Well, actually, if I'm a valued physician, then what are the limits on what I can do safely, humanely? As a doctor, we could work every day, 24 hours a day forever, which some people in the Daily Mail comment section think we should do. But there's obviously problems with that because we remain human beings throughout all of this. And so a lot of that balance and prioritization comes from looking at how you work and how you want your work to look. The second 2 kind of elements that have been identified are how a practice is run. Now, one of the joys of being a GP is that rather than having to work for one employer, the NHS, which has a largely top-down managerial style, and there is differences between hospital trusts, but change happens really slowly. And if you've ever been involved in an audit trying to get it to become some kind of policy in a hospital, I'm really impressed because you'll have done it within a 2 or 3 year placement there. And that's probably the pace of change that sometimes things can take. I have to say I'm stunned, and not just me, so many staff are stunned at the pace at which change has been able to happen in the NHS during the past few weeks of the coronavirus crisis. It's been a completely different thing. So one of the benefits of general practice is that as independent contractors, one GP practice may be run completely differently from the one next door. So one may have an open list, so people come and just sit and take a seat, wait for their appointment. Others may have telephone triage. Others may run a personal list system where you're responsible for a list of patients yourself, that you have to see them and they have to come and see you when you're in, kind of thing. How your practice manager does things, how as a partner you divvy up your profit share, all sorts of different ways of working things. So hopefully one out there that really suits you. And kind of a common theme within that is that when people feel like they're in control of their situation, they tend to be happier. So if you're working at a practice where you feel like you can make change that benefits you or the practice, you're much more likely to be happy with that. And the last one, I mean, again, this seems obvious, but let's never forget, sometimes feeling good about yourself is because you've got good, positive relationships with other people, both professionally and personally. And when you communicate well with other people, I don't think I need to say an awful lot about that. It's fairly clear, isn't it? Be nice to people. So that study is a kind of nebulous way about talking about resilience and how to kind of have a framework. So there's 4 kind of principles in your head. If you prefer, this is kind of more a stepwise kind of approach, kind of a checklist, as it were, and that's because we all do things in different ways. So following these through from left to right, then top to bottom, the first kind of thing to do to help build resilience is about learning to accept change. So the example I have here is that I wouldn't say I'm that fussy, but I remember as an F1, I'd done like the patient list and I was quite happy with how it looked. And then obviously you move on to a new job. I had to accept the list that was done how the consultant wanted it to be done, even though they were barely using it. It was more for me, but that's how it had to be done. And I found that really frustrating, which sounds ridiculous now when I say it back, because now I guess I've kind of learned to be like, well, if the information's there and I can get it, it's not making my life any difficult. And it was trying to be objective, I guess, about what was going on there. Some might call it cynicism, I suppose. The kind of the longer you stay working within the NHS, the more you sort of realise that change is inevitable. And GPs with decades of experience beyond me talk about the fact that every so often things change around, but largely things actually stay the same. So I think a great example is the idea of primary care trust PCTs when I was a medical student becoming CCGs. They both manage how general practice and secondary care is commissioned. They both have loads of managerial staff, and there's just slight differences in how they run, but essentially it's pretty much the same. There's a lot of people that get in a hoo-ha about how things are going to change or not change, but by and large, things don't look that different at the end of it. So I guess part of learning to accept change is about the experience of recognizing that change isn't necessarily going to upset your life and how things are. The next kind of step to resilience is about continuous learning. So as much as, and I genuinely mean this, as much as I hate to say this, this is one of the good things about having a portfolio and appraisal every year, because it kind of forces you to do stuff. You can totally see how easy as a GP it would be to just sit in your room and do things like they've always been done. If any of you have got friends who've gone to Australia to be a GP, one of the common things that my friends who go tell me is that they're really valued by their Australian colleagues, because kind of in Australia there isn't guidance like we have it in the UK. So there's no such thing as, for hypertension, so start with calcium channel blocker or an ACE inhibitor or ARB, then move on to the other one, then add in a beta blocker or a diuretic depending on whatever else is going on. There's none of that. They just do what they like. So you'll have patients from different doctors just prescribed on whatever. Now that suits them, but actually there's not a great way of evidencing what you're doing and what doing the right thing necessarily for patients. And one of the things we're really sort of trained in doing as UK trained GPs, which is one of the reasons they really like us around the world, is that we're really good at keeping up to date with things by and large. One of the benefits of having a trainee like an ST3 in a practice is that often your ST3 will be the person that knows the most about things. ST2s are often really good as well because they're doing AKT revision often, so they're learning all the facts and guidelines and can quote them back at you. And certainly we've at Dunstan have often had ST3s who are able to just kind of quote the latest guidance for things because they've learned it to memory. So having other people around learning often promotes learning within a practice. I think a really important step and something that changes from this year to next is that you will have to take much more charge over your learning. Now, for all I know, some of you are sat here incredibly bored, and let's do a little test to see who's listened to this. So if you've listened to this, I want you just to write down in the Facebook comment section a word that begins with the same letter as your first name. So we'll see who's had a listen. And this could be really embarrassing for me, couldn't it? Yeah, so I guess taking charge of learning is, and yourself is really important, because yeah, you might be sat here kind of bored during some of the sessions. You'll think, why have I had to learn this kind of thing? But it's what's been provided. So the idea is that overall what's been provided probably fits your needs, I guess. 75% of the time. Is that an ambitious target? I'm not sure. Something like that. But once you move out into kind of being a fully fledged GP, there won't be such a program of things anymore. I mean, Bolton CCG and a lot of CCGs put on a monthly teaching session, but that can't really be it for you. So you kind of have to look at, well, what is it I want to learn about? What do I need to learn about? And make steps to do that. So one of the things I'm doing for my appraisal this year is I'm meant to do some knowledge building around knee and shoulder joints, because I've decided I don't think I know enough about orthopedics and MSK things. A few years ago, a big thing for me was to do about diabetes, which I now love, and I've done loads of diabetes, and I keep doing diabetes learning. But it's a bit easy, the diabetes learning. I've done a lot of it, so I need to push myself into things that I'm less comfortable with. And I think that leads into the next ideas of self-identity and defining purpose. So who am I and what is it I am doing here? So, for example, I'm currently a salaried GP at Dunstan over in Braitmere. Now, when it came to getting a job there, I'll be honest, I was a bit strategic about this. So I knew that one of the partners was going to be retiring, and he did almost all the diabetes work for that practice. So when I went for my interview, knowing that I was interested in diabetes, I made sure to mention that I was interested in it, because the whole point of that was to demonstrate, look, I can be useful to you that's here. And, I'm quite comfortable being someone that likes a lot about diabetes. It wasn't foisted upon me. So that became part of my identity, actually. And diabetes is something I find really interesting. So I like endocrine conditions because you tend to have them for most of your life. And I love that kind of chronic care of people. And there's some fun things that make sense. So if I do something with your blood sugar, I can bring your HbA1c down, or your thyroid test. I love explaining a TSH and T4 to patients. So it fits the kind of conditions that I like seeing really well. And that then obviously has allowed me to kind of cultivate relationships. Nice segue into point 6 there. So I work really well with the nurse who does most of the diabetes stuff, and I've got links with various people around the Northwest now involved with diabetes because it's something that I enjoy, and that makes me feel happier. If I'm having a bit of a bad day, sometimes it's really nice to see that my last phone call is to someone who I'm doing a checkup on for diabetes, because I know that I'll probably feel better after speaking to them. If you've ever worked with me, you'll know that I love skin problems. So eczema is another kind of thing for me. A child with eczema that I can explain about emollients to, that really cheers me up, that kind of thing. So those first 6 points are kind of things that you have to think about. And the last 3 are kind of actually reflecting and looking back on what you've done to shape the future direction. So it's all very well me loving my diabetes and doing that, but if all I do is diabetes, then I'm going to de-skill in other areas of GP. So I've had to be really careful not to make all my CPD diabetes, or to only see diabetic patients, for example. And so part of that comes from reflection. So looking at your list and going, do you know what, Seb? Almost all your patients are chronic mental health problems or diabetes. And that's not very good for anybody, because I'm not then useful when I do other things. So actually it's then looking at, okay, well, so if I'm really good at diabetes, I should probably just see the people who are really bad, and then let other people deal with the other things and use my skills to upskill them, for example. And in that way, I can create some balance in what I'm doing. And if we go back to the idea of thinking about my journey up the mountain and the mountain lions getting in my way, if I could have anticipated that, and I think next time I develop sort of more interests, I'll be better at recognizing when I've maybe taken on a bit too much because I enjoy it, it's then actually been detrimental to me. So you kind of learn from your past mistakes. I suppose the point of this framework is something to come back and look at and go, why is it I'm feeling really burnt out? Why do I feel like I'm just getting nowhere? Where have I fallen down on this kind of grid of things I need to do? Have I got stuck at, I can't accept this is different anymore? If that's the case, and it's actually looking at that area of things. Or have you kind of got to a point where you feel like you're taking charge of what you're doing, you know where you want to be, but you don't know anyone there to help you get there. So say you're really interested in women's health and no one else in your practice is, well, and no one values you for doing that. So you need to find a network of people who do value that, to cultivate those relationships, to develop that. And then in that way, you can then move on to think about how to balance that within your life and reflect on the whole experience. So could you have recognized that that was a problem before? And the idea of this is to, not that you need to do this day in, day out for every decision you ever make, but when you're struggling, to come back to something like this and say, where is it I've got stuck? And then that way, hopefully, you can find your foothold to climb out of the hole. Now, there's an awful lot of focus there on resilience in terms of what you need to do as an individual, but let's not forget that really important point from Claire Gerada and many other critics, in that sometimes it's not about you. Sometimes it is something else that's going on. And so if that's the case, and you're fairly confident that it's not you, it's to do with where you're working, the system, the place, the managerial aspects, something like that, one of the first things to do, and we talked a bit about this when we did ethics, is about identifying the actual problem. And again, that's sometimes harder than it may seem. So if you're always irritated with another member of staff, you need to understand why you're irritated with them. And sometimes these things can develop without you really recognizing what it is. So it's important to kind of drill back to how did this start? What is the problem that you've got? And other people can sometimes be really helpful. Unless you're talking with trusted, confidential kind of people about that. Once you've identified the problem and you know what it is, well, then you need to ask the question, well, are there solutions to this problem? So generating a list of possible solutions, which I would say should range from, I'm going to kill the person that's annoying me, to I'm going to ignore them further and seethe with rage and become really introverted. And the answer is probably going to be somewhere in the middle of there, but thinking about the extremes sometimes can help you generate more options. Now, can the options be put into place? Well, I'm not going to kill someone who's irritating me, because it doesn't really solve the problem in a permanent way. It does. It just creates a brand new problem that I'll have to deal with. So looking at those solutions, if they can't be put in place but seem like a good solution, well, why not? What's the barrier to that solution working? And then actually it's taking that and saying, well, is there another way to achieve the same goal? So this is your kind of brainstorming idea. So I want to drive from Manchester to Birmingham, but the M6 is shut. So I can sit and wait in the queue of traffic until it reopens, or I can take another route. So that's a very literal or metaphorical, what's the word? The wrong way around, haven't I? Very figurative way of saying there is another route to get to where I'm going to, but it may not have been what I first thought, and it may take longer to get there. But if my goal is to get there, well, then I need to figure out how to do it. And the last bit, I think it can be the hardest bit. If you've gone through this process of thinking about the problem, possible solutions, and how you can overcome barriers to those solutions working, it's then about being assertive. And that can be really challenging when you are, say, a junior person or feel like a junior person within a system to challenge things. But that's why, coming back to that first point, so talking to other people about it, because if other people agree with you, you've got much more of a sense that you are probably right, and that should hopefully give you more confidence to tackle whatever's going on. Now, it's obviously really important that you remain respectful throughout this. That doesn't mean necessarily deferring to other people who feel they're senior just by virtue of the fact of the time they've worked somewhere, or that they've professed to be an expert in something that you're bothered about. But it does mean sometimes adjusting your strategy to get them on board. So let's take an example, which I think a lot of practices have had to deal with recently, which is, how on earth do we move from an appointment system based on patients booking in to see a GP to a largely triage-based system when we don't currently operate that? So let's say we've got an old-timer GP who's never really done telephone triage or consultations before. And within a few days, it's really apparent that they just cannot handle it. They're bringing everyone down to be seen, and which means that other people feel like they're doing more work. After a brief chat in the coffee room, you sort of recognise that not only do some of the doctors see this, so do some of the reception staff. And actually, one insightful secretary who's known this old-timer GP knows that that's just how they've worked, and they're really struggling with the change. And actually, they feel really bad for not being able to do the same as the other GPs seem to be able to do. So what are the solutions to that? Well, let's think of some. If we're in a room, I'd have a chat with you, but I'm going to try and give the solutions that I hope you're thinking about now. So can we perhaps send that GP on a training course to learn some telephone triage? Well, pros of that are it's a really good skill. Cons are, well, is it worth it for this GP? I mean, how long are we going to be doing this for? Is it going to be worth the amount of time to train and learn these things? Indeed, is there a course that's going to be available to do that? So there's some problems with that. And then the other kind of issue is, well, what if there's someone that just can't be trained to do something because it's just not something they're good at doing? So actually, what I recognise there is we've not really defined what the problem is. I've assumed the problem is that this GP just can't do telephone triage, whereas actually the problem is that we've got a GP who isn't able to do triage in the way that everyone else in the practice does. The problem is actually with the practice, not with the individual GP. So it's a system-based problem. Now, if we think about what needs to happen here, most patients in the coronavirus crisis can be managed on the phone, but some do need to be seen. Well, this GP, Oldtimer, is an excellent consultant. They've done this for years. Patients really trust them. So why don't we make this GP the one that sees the patients? It's a possible solution, and the cons of that, I suppose, are, well, are there increased risk of infection? But it's worth having that discussion around that with the person. Now, actually, on discussion, we realise that this person actually is in a vulnerable group because of a medical condition they've got that we'd forgotten about. So that's not going to be a solution for us. But again, our goal is to say, well, what skills has this person got that we could use? And actually, when it comes down to it, this person is brilliant at doing people's medication because they know all the patients. They know what medicine Mrs. Smith's been on for years and why she can't have this brand or that brand. So actually, let's divert all the admin work to this person. They're not thrilled about it because they do like seeing patients, but actually it frees up the other staff to do loads more telephone triage. And actually all the work still gets done as a practice. Now, I've told that story in a practice that sounds pretty supportive, but it's involved some really difficult discussions, hasn't it? So the first person in the coffee room has had to sit there and go, oh, Dr. Jones is really struggling with telephone triage. I mean, it's a risky thing to say, isn't it, in a practice? Equally, it's really difficult for Dr. Jones, the doctor affected, to have told the secretary, I'm really struggling with this and I feel really guilty. Also, it's then difficult to kind of go back to the beginning and say, what is the problem we're dealing with here? We've kind of started our solutions thinking, well, we need to train this GP to do what we want it to do. But actually, it's forgotten what the problem is. The problem is, how do we use our staff in the most effective way? So by going back to that problem, being honest that we got the problem wrong to begin with, we can actually then go and look and see what we need to do to make things work better. And if you're a resilient kind of GP, so you've worked on yourself, you recognise yourself, you'll be in a much better position to tackle these workplace stresses in an effective way that doesn't result in arguments or resentment or difficulties. So I guess in summary, a large part of resilience is about looking at yourself, knowing how you're going to react to things and never losing sight of the prize. Why are you doing this and what do you want to achieve? Along the way, use frameworks if you fall, and never forget that sometimes it's not about you, it's someone else.